Hey everybody, it's Kevin and it's Donna from RPH Ally and the Deprescribing Show. Excited to have you guys here. If you haven't joined RPH Ally, join it. If you haven't gotten the soiree recordings, get them. And if you haven't joined Donna's channel, get there. So we're so excited to present to you guys another really fun case from Donna. Life can get a little bit wild and chaotic, and it becomes even worse when we're having issues with fall and then mixtures of anxiety and depression to come along with it. So we'll talk a little bit more about that right after the break. All right, Donna, it's wildfire season in the Northwest for me. We've got all kinds of life events happening for you. And I feel like the topic we're talking about today, Donna, are the ones that get brushed under the rug because we have so many other things happening. And then when they actually occur and hit the family, it's when you go, oh no, I wish we would have paid attention to that. So without further ado, I'll share my screen and let you take it away.
Awesome. So thanks, Kevin, and always great to be chatting with you. And I love going through these cases with you. So just really want to highlight this particular case because we find that people are treating anxiety and they're treating depression. And as we've talked about before, things get added on, added on, added on. And then what happens? We have a tangled web that we've weaved. And we really have to be careful about this because, people fall, of course. We talk about this all the time. But what's happening with these meds that people do not want to touch? And it really causes havoc for folks. So we're going to get into this case and be thinking about DG. And so DG, it's just a little bit of a crazy story, and I'm going to I didn't necessarily break up the two hospitalizations that are kind of back to back, but I'm going to talk you through it a little bit as we go through to share the story a little bit more. So we have this 75-year-old male, and he's admitted due to syncope. So I seeing him, or kind of catching this case on his second hospitalization, and he was first hospitalized just a few weeks ago. And on that first hospitalization, he was on a ladder, 75 years old, on a ladder. So we're thinking, okay, he's doing kind of okay if he's getting himself up on a ladder. Had kind of like a dizzy-ish spell of sorts and ended up falling. And that was his first hospitalization. So it was a traumatic fall that he had. And eventually, though, a couple weeks, and he was back at home, grocery shopping, and coming back home from that, walked up a few steps and had a syncopal episode. So here we are having syncope, where the first one, it wasn't really stated syncope for that first hospitalization. It was just like a dizziness kind of thing up on this ladder. So this one was an actual syncopal experience or episode that he had. So when I'm looking at these numbers and thinking about what's going on with him, he's had anxiety and depression for some time. I couldn't really see how far back these medications went, but they were at least which we'll go through. Some of them were like around 2008, and then others were started around 2019. So it's been going on for some time, and there's been these additions happening. He also has issues with hyperlipidemia, but there's no issues with hypertension or diabetes, some of the things that we might see when we're treating people for years on antipsychotics and antidepressive medications. So those are some of the things that, okay, maybe it isn't all of this metabolic syndrome that he's experiencing. But when he prior to his first hospitalization within these last few weeks, his anticholinergic burden was at a 4. So not horrible, but it's more than a 3. So we're concerned because 3 or more gets us into trouble. He ends up in the hospital 2 hospitalizations later, and he's up to an 8. So, and that's often what we see is when people are hospitalized, if there is some anticholinergic burden, there tends to be increased anticholinergic burden in the hospitals, and that's been shown in various studies. Polypharmacy for him, he was on 8 medications, and hospitalizations, etc. He's now there was 10 at that hospitalization, at his first hospitalization, so a couple being added on. And then frailty score, he was up on a ladder, so I'm giving him a 2. Maybe he wasn't out running and everything else, but I figure 1 or 2 somewhere in there. He was probably a pretty active guy, it sounds like. And now, like after that first hospitalization, he was at a minimum of a 4, and he is deteriorating from there. So, so further on down, and probably more like a 6 or 7 as of today. So, lots of things happening with this gentleman. So, concerned for sure. So, let's go to the next slide. And we can take a look at some of these meds.
I was wondering, Donna, on that side, the AC burden and the polypharmacy burden, for you, the number of cases you've been through and seeing the admission and discharge process, how
Mhm.
often are you seeing, Donna, that those numbers go up and stay up after they're discharged?
Absolutely, more times than not. Um, the way that the hospital discharges folks is they have their start these meds, keep these meds, and stop these meds. And I can't always say that that evens out, or that there's more stopping than there is adding, if you will. Um, so definitely an issue. And of course, you understand there's an acute issue that has gone on.
Yep.
And we've mentioned this before too, that some of the hospitalizations, they're not necessarily they meaning the hospitalists in general, they're taking care of that acute problem. They're not looking necessarily at these chronic issues that have been going on for a really long time if they're not presenting as problematic at that point. And I can understand that. They have, plenty of patients that they're going through. We know that deprescribing is a process. There's a lot of monitoring and follow up, and they don't necessarily have a long history with these patients. So, it really is our healthcare system that needs to look at this a little bit differently than just putting it all on the shoulders of, you know, whoever is caring for the patient at that moment in time.
Well
So,
said.
um, so you can see these medications that are listed here, and I did highlight a couple of ones in different colors just so I can tell the story a little bit more. So all the meds that are not highlighted, they were meds that he has had a history of taking, and that he was still on between these hospitalizations. The topiramate and prazosin, and we're going to get into some of the issues like the unknown things about some of these meds, but those two he was on prior to these hospitalizations. However, they were discontinued between the hospitalizations. So probably realizing that we don't even know why he's on these, and they're not doing him any good. Where it's at. So those were removed via the hospital lists. And then the oxycodone and methocarbamol, those were actually started after his first hospitalization. They were continued on when he left, and really present some issues for this patient. So, but look at some of these meds, and when we're looking at the at first, and we're going to go over this in the next slide too, but just briefly, some of these medications are just being added on, and there's duplications of therapy. So things like quetiapine, mirtazapine, duloxetine. Why are we on these 3 different meds? I couldn't even find like any updated psych notes or anything like that. So you kind of start questioning, like, how long have these been going on for?
Yep.
And what's the purpose, the continued purpose? Maybe in the 50, when he was 50, maybe it was appropriate at that time, or, maybe there was another episode, something that happened when he was 60, but are these relatively high doses, especially of quetiapine, are they still really necessary? So looking at this, we really want to try to get this timeline going and try to understand like what was first, what was second, kind of thing. So it does look like quetiapine was started well before these other two, but the mirtazapine and duloxetine definitely go back to at least 2019, and then quetiapine prior to that. Um, and then atorvastatin, there's this hyperlipidemia issue. It's noted. It's been going on for many, many years, since the 2000s. And we can go, okay, medicines might have added to this too. They're not necessarily helping dyslipidemia when you're looking at the antidepressants, antipsychotics, especially.
Yep.
So, all right, you can kind of understand that maybe this is necessary. Maybe there's family history going on too. But, how are his numbers now? Well, when I went to go look, couldn't find any. The last I could find was from about 5 years ago, and it was okay. It wasn't horrible. So, where are we at? And is there some weakness that happens over time with the statins, and especially a high dose, high intensity statin? So those are things to be thinking about as well. And I never like to see the muscle relaxants and the opioids together. You can understand, traumatic accident, maybe something had to be done for a minimal amount of time, but certainly nothing to continue on, especially an older gentleman going home. So not surprising that he's hospitalized again for another event. So we can move on to the next. I know I just talked about a lot of these notes, but we can go on to the next slide and
The only
really
thing I
see.
have on here, Donna, is what you just highlighted in those pain medications, that you and I can both see that it is a very typical scattershot pain medication approach. Not only the oxycodone and methocarbamol, but once again, there's our good old friend. Let's throw on another lidocaine patch.
Yeah.
And oftentimes, duloxetine is being grabbed for to go, hey, we'll add something on that helps with nerve pain and increase the dose a little bit to see what we can do there. So lots of multi-use potential utilizations of drugs inside of there that I think are fascinating for this age group.
Yes, absolutely. Fascinating and hazardous too.
Interesting.
So we have medication concerns, and of course we have to label it. The number one concern here is polypharmacy, because polypharmacy has not been treated throughout. This person has unfortunately having multiple medications that are causing issues. So in continued issues, because if we see the anticholinergic burden going up, and we see the polypharmacy number going up, and the frailty score going up, we're not helping. We're not helping the patient. So how do we get those numbers down? So we just talked about this combination should be avoided. So opioids and muscle relaxants should totally be avoided. Quetiapine, mirtazapine, duloxetine, all duplicated, no psych notes that I could find. And I was kind of surprised, just thinking about the trauma that he'd been through. I was kind of surprised that there wasn't a psych eval in the hospital. You typically see that. So it's a little bit surprised that I didn't find the notes on that. And I want to just break out these a little bit more. So mirtazapine, I was trying to figure out like, okay, what could be causing some issues here? Like if these have been on for some time for this patient, what changes could be happening? And when we look at mirtazapine, its half-life is 20 to 40 hours, which is very long. And so there's a stacking that occurs with that potentially. There's an issue with glaucoma with this medication, and he does have glaucoma. He's being treated for that. And lastly, what I found very interesting, and I tell you, every time I look up meds, I'm learning something new too, Kevin. So, um, and it's, and this is what we tell our students all the time. We're always learning something new. So, there's clearance reduction of mirtazapine, especially in older males, up to 40%. In females, it's only 10%, according to what I could find. So big difference there. And so it's kind of, if you think about it, the opposite of zolpidem, right? So you're allowed like more of a dose in males than females, but
Mhm.
so here we're kind of having that opposite effect. So mirtazapine is not cleared as well in males as they age. So not only are we getting this stacking because of the hours of the half-life, but now there's potentially more stacking occurring because as our older adult male ages, we're probably getting some reduction anyways, in clearance. So I just found that to be intriguing, and maybe there's something to be said about this. Maybe this is not the med for him any longer. Topiramate, we really don't have a known indication. I really wasn't able to find it in the chart as to why it was started, when it was started. So, kind of a mystery med to me, and not quite certain its indication for this particular patient. Prazosin, again, it can cause orthostatic hypotension, syncope related. Not really a known indication. His blood pressures are really good. So, don't really know what's going on there and why he was on it. So again, another mystery med.
Huh.
And then atorvastatin, I couldn't really find any updated lipid profile. So a lot of things to question here for this patient. So we can move on to the next slide, and it's kind of the recommendations that we could consider. And, can this happen all at once? Maybe not. Maybe some things can happen. There's some things that we probably have to do more in a step-by-step approach. So it would happen all within the hospitalization? Probably not, but something to be looking at and hopefully passing off as we go through the transitions of care. But first and foremost, methocarbamol should just be taken off. That is a 3 for anticholinergic burden. So it's the highest level you can have for anticholinergic burden. It was recently started. He had syncope, which is also a problem with this medication, went home on it from his first hospitalization, really shouldn't be combined with the oxycodone. So I would totally take that off for this patient. Previously, when I looked back at some of his past medications, he has had cyclobenzaprine before. That was years ago, but still, at this point in time, I really don't think that a muscle relaxant is anything that this patient should be using and should be avoided, especially if other pain medication is more important for him. After having the traumatic falls that he's had, it's probably important that the pain be relieved, and with that, maybe that muscle relaxation might occur if he's not so tight with pain,
Right.
potentially. So, that I would really like to see discontinued. Quetiapine, um, I don't think this would be the first drug I would stop, though I don't love the dose by any chance. I think eventually it could be reduced or discontinued, but if I really had to pick out of quetiapine, mirtazapine, duloxetine, I would totally go with the mirtazapine first. And the reason for this is just because of some of the things that we had just talked about in regards to the long half-life and having a reduced clearance in males. I just think if we're looking at risk versus benefit, I think right now mirtazapine is probably the riskier drug for this patient. Quetiapine is a short half-life. Like I said, I don't love the strength, but we have to do these in steps most likely. Duloxetine is probably the med I would want to keep on, especially if it was added on later. So if quetiapine was at 200 milligrams originally,
Yeah.
and you weren't getting um, the results that you were looking for, then eventually you add on mirtazapine and duloxetine. Why are we keeping on the quetiapine too? So I think that if there is resolve with depression and anxiety, it could very well that duloxetine is actually working. There's room to move with duloxetine still on this patient. So I think that that might be a nice balance to work out. So if I were to keep one of these on, which might very well be necessary, not knowing the whole history of this patient's anxiety and depression, I would most likely try to work with the duloxetine a little bit more. With we already talked about topiramate and prazosin being taken off at the hospital, so those are discontinued. Wonderful. Lidocaine, not quite certain about its use. It was being used prior to an at-home med, so just determining whether or not continued use is necessary. Again, we're dealing with pain right now, so probably not the best time to just take that off and not understanding its full use at this point in time. So something to be considering. Atorvastatin, we really need a lipid profile. If he's gotten weaker over time, he states that he just feels like he has weaker muscles or can't quite do as much. It might be something that we can back off of. I wouldn't say necessarily stop, but I think that we could potentially look at that and reduce atorvastatin. And then the travoprost is probably something that needs to remain on at this point in time. Probably would need ophthalmic review in order to adjust if necessary on that.
So just getting rid of a couple meds then, Donna.
Yeah.
Basically the entire regimen we're thinking
Yeah.
might be unnecessary and or problematic. Yeah, I think the way you broke that down on which ones to discontinue, I wanted to highlight for the audience here is that really looking at how are we going to eat the elephant. One thing that Donna said right off the bat is methylcarbamol had the highest anticholinergic burden score. So something she jumped onto right away, hopefully related to or potentially causing some of these additional problems because of the start date on that individual drug. My mind was reeling and I'm looking up on my phone to go, what are the dosing components there? Because when I saw prazosin and I saw duloxetine, quetiapine, and mirtazapine, I was thinking, hey, it's a male, so it could be BPH related. That dose is not BPH related. But the other piece that went in my head is I know that it was used off label for nightmares at one time. Again, the dose is too high, for it to be in that space as well. And so really the overall sleep study and wonder on how we're going to get this gentleman back to where he needs to be for sleep without medicating his overall level of sleep is really interesting to me. And then the exact same thing to be said with his overall psychiatric care when it comes to the duloxetine. I feel like we often put meds on for depression and anxiety, and should not be the case with Mr. DG. But after the loss of a loved one, sometimes anxiety ramps up pretty significantly. We think, we'll throw on an antidepressant with anxiety and it's related to a life event. And then we never go and reevaluate that. And so all the serotonin, norepinephrine effects of an individual drug that we think are benign until they're not, we don't go and re-explore. So I'm glad to see that you've really addressed the entire group there. And then we did have a couple questions real quick, Donna, from Jim asking about rounds, like attending the rounds while this patient is in the hospital to be able to get some additional history and questioning. And then he follows that up with, do your recommendations typically go to his primary care provider in the discharge notes?
Yeah. Great questions. Actually, I'm working remotely right now on these cases. So it's more or less direct information to the doctors and like recommendations directly to the doctors. But in regards to notes going on to the providers, it really depends upon the system, unfortunately. So depending upon whether or not the doctor is in the system, they will totally see the notes if they are. Everything is there from every telephone discussion to appointment to hospitalizations. So if they're in the same network, then yes, they would see the notes. If not, it's questionable and not necessarily. It's really like, oh, here's your discharge, paper, information type thing. You want to bring this to your doctor at your follow up, and whether or not that actually happens, it's not up to the healthcare system at that point. It's up to the patient at that point in order to bring it.
Yeah, I think there's a really good highlight there for the end of our discussion for the day is just that documentation trail, how it flows in transitional care management, may be one of the most broken parts of healthcare. And that really puts the advocacy back on the individual patient and the patient's family to be
Mhm.
able to move those pieces of information across, which is
Yeah.
really unfortunate and is a good call out for the health information exchange folks that are out there for us to be able
Mhm.
to give more robust documentation upon send out. I think one thing that Don and I's colleague and all of your guys' colleagues, Jenna Quinn, is really pushing on for pediatric weight-based dosing and making sure that it's mandated to push across. I think there's lots of things, Donna, that I'd like to add to that list when it comes to deprescribing and
Yeah.
optimization for sure. But Donna, thank you so much for this
Thank
run
you.
through and breaking these things all down for us. Any parting words for the crew?
So join me next week for another riveting case. So we're going to be looking at the effects of antibiotics and our older adults. We really have to be careful about our selection. So we'll be talking about that and how an antibiotic, you think you're helping them as an outpatient, and they end up in the hospital because of it. So we have to tread carefully there.
I'm nerdy stoked for next week. And thank you so much for this rundown. If you guys have any questions on the syncope, anxiety, depression
Yeah,
case, please hit us up on our PH Ally. Make sure you get Donna's book, Med Strong, and we'll talk to you guys next week. Have a
sounds
good one.
great. Thanks so much, Kevin.
Bye.